I try to imagine a fellow smarter than myself, and then I try to think, what would he do?
Charge up your axons, ready your receptors, and shift your lobes into upper beta phase. You are listening to Smart Drug Smarts, the podcast dedicated to helping you optimize your brain with the latest breakthroughs in neuroscience, nootropics, and psychopharmacology.
Hello and welcome to the long overdue 20th episode of Smart Drug Smarts. Obviously, for those of you who have been listening to this podcast and wonder where it went, it's been a long time. I think it's been about 2 months since I last published, which is absolutely inexcusable. And the first couple weeks, there was kind of a few reasonable reasons why the episode was late, and then after that, it was just one of those things that it got worse and worse. Here's the analogy that comes to mind. It's like if you've ever been at like a busy dinner table and you've gone to the loo and just in like the bathroom that's off the main room where everybody is, and while you're in the bathroom, you crap yourself somehow. There's just like it's a disaster. It's a total mess. It's like, oh my god, I just crapped myself at a dinner party, and you just know that you can't go out there because you're going to humiliate yourself. But of course, the longer you wait in the bathroom, everybody knows that you just went into the bathroom for 2 seconds and like what's he doing in there? And it's like the longer you wait, the worse it gets. And so you just keep hiding, and it keeps getting worse, and you keep getting more worried. And anyway, that's kind of how I felt about finally getting this podcast episode out. I'm so sorry. And anyway, I'm sort of back and stabilized, and we'll be back on a much more regular production schedule from this point on. My summer vacations and travels and a few technical issues, including a hard drive failure, are, I think, seemingly now all behind me. So happy to be back. We've got a great episode lined up for you today, which I think is actually going to be a really interesting sort of spitball episode off the main topic of nootropics, but one that certainly has a lot of relevance, which is the placebo effect. We're all familiar probably with the placebo effect as far as drug studies to see if something really works or not versus a non-active and inert substitute for a particular drug, which we call a placebo. We're going to be talking with one of the world-renowned experts on that, Dr. Fabrizio Benedetti from Italy. But more on that in just a few moments. If you stick around until the end of this episode, in the ruthless listener retention gimmick, I'm going to tell you something that might make you want your doctor to start doing drugs. But first, let's do This Week in Neuroscience.
Smart Drug Smarts. This Week in Neuroscience.
Okay, so very interesting study recently published in the Journal of Neuroscience called The Mental Cost of Cognitive Enhancement. And specifically what they were studying was something called transcranial electrical stimulation, which is something that I want to actually devote a full Smart Drug Smarts podcast episode to sometime in the fairly near future. What the idea is essentially that by putting electrodes on the outside of a person's head and running a small current through different parts of their brain, you can have neurological benefits. Basically, that slightly electrocuting yourself can make you smarter in certain cases. And so they were sort of trying to tease apart the details of this. And we're studying what they used. It was about 20 college students or people between the ages of 20 and 30. And they ran a bunch of tests of learning both on knowledge acquisition and then on what's called just a tough word to pronounce, automaticity, basically how automatic something is used within the brain once it's been learned. For example, we all learned to read, learned our alphabet and our numbers and stuff like that. And, at first these are just weird squiggles on a piece of paper. They don't have any inherent meaning, but soon we're able to learn them completely automatically. It's like you see the letter R, it's part of a larger word, it's part of a larger sentence. You're instantly getting this full idea that's coming to you in this cavalcade of characters, and the fact that there's some individual R's within that string of characters is totally irrelevant. It never even flickers on your conscious thoughts by the time you know what you're doing with reading. So that would be sort of the automaticity of the learned knowledge of what the letter R is. So anyway, they did this study. Needless to say, they had a control group that wasn't getting any neural stimulation through TES, although they had a fake electrodes that still gave a slight buzzing feel, so they thought they had something. And then they had 2 other groups that each received transcranial electrical stimulation to different parts of their brain, the posterior parietal cortex and the dorsolateral prefrontal cortex. You can look up on Google where exactly those parts of the brains are. I won't go into that now, but anyway, what they found that was really interesting was there was pretty much no question that they can improve different facets of cognition with transcranial electrical stimulation. But what was interesting is in each case, there was a trade-off. There was something else that was lost. With the first of the two, the posterior parietal cortex, the stimulation there led to a large decrease in the amount of time it took to learn these new fake symbols that these college students were shown. But conversely, they actually had less automaticity for the knowledge once they'd gained it. So they learned it fast, but it was something that even though the knowledge was there, they kind of had to consciously summon it up, I guess, rather than being able to just instantly have it at their mental fingertips. And for people that received stimulation to the dorsolateral prefrontal cortex, the exact opposite was true. These people took a longer time to learn than both the group that received the real stimulation elsewhere and the control group, but they had greater automaticity with the knowledge once they'd gotten it into their heads. So really interesting. There was a direct seesaw with these types of stimulation, these areas of stimulation. The quicker you wanted to learn something, the less automatic the retrieval of it was. And conversely, if you wanted to stimulate yourself in such a way that you would have very quick automatic retrieval, it was going to take you longer to learn the darn thing. And obviously, this is the tip of a large iceberg of a lot of research, I think, that's going on right now in the transcranial electrical stimulation world. So more to come on that, but that's a sneak preview. And I will put the link to this Journal of Neuroscience article, which is definitely worth reading if you want to geek out, on the website.
Smart Drug Smarts.
Okay, so before we dive into this main interview with Dr. Benedetti, who is one of the world's leading experts on placebo effects, is published all over the place for the last decade plus in these waters, why aren't we talking about placebo effects at all? I guess it's worth circling back to that idea. So I was walking home the other day thinking about smart drugs, as I frequently do, and wondering about how I've gotten a lot of different results personally than some people that have been listeners who have tried different things and either felt more or less than me subjectively on different substances that presumably we've all been taking the same stuff, barring things like actual differences in the pharmaceutical grade of the drugs in question, or major physiological differences between the people, like maybe one person weighs twice as much as another and they're taking the same dose. Is there a way of teasing apart these differences in subjective effects? And that got me thinking about placebo effects. Quick backstory for those of you who might not be instantly familiar with what a placebo is. So when they're trying to bring a new drug to market, let's say it's a pain reliever, and they want to know if the pain reliever actually works. The weird thing is, I guess it's not really that weird if you know human psychology, but when a doctor gives you a pill and says, hey, this is going to make you feel less pain, and gives you a pat on the head and smiles at you warmly, and they're wearing a professional-looking white lab coat and you're in a nice medical environment, you're probably going to feel like pretty good about that whole situation, even if you're eating a totally inert pill, which, in the old days when they first started doing this was, sort of the classic sugar pill. I think they don't actually use real actual sugar for placebos anymore. But anyway, so a lot of the results that people get tend to be coming from their own mind, essentially. Not that it's necessarily a fake result. Your own mind can do all sorts of powerful things within your body, but that the active ingredient is more the situation and your expectations about that situation than the pharmaceutical itself that you're actually taking. In something like those of us that are taking nootropics that we're getting either over the counter or through some other means that aren't necessarily a doctor's office prescription situation, a lot of that exterior setting that kind of primes you to feel something isn't necessarily there. On the other hand, listening to a podcast like this with somebody trumping up some particular pharmaceutical, I try to be as neutral and unbiased as I can, but on the other hand, we're listening to a podcast about nootropics. So, listening to something like that and getting all excited about it and waiting in eager anticipation as whatever it is get FedExed to you in the mail, that can have expectation powers too. So how much of what we're feeling when we take these things is us actually being smarter, us actually getting a cognitive boost versus just sort of the expectation of being smarter, which maybe we could get through some other way without having to take a little pill at all. Anyway, thus my interest in placebo and wanting to talk with somebody who's a gosh darn bona fide expert about it. And with no further ado, let's jump into the interview. Okay, so I'm on with Dr. Fabrizio Benedetti, who is one of the world's leading authorities on placebo effects. He's been studying this for, I think, 15 or 20 years based on sort of the length of scholarly papers and when these things were published that have placebo and his name all over it. So can you tell us, Dr. Benedetti, how long have you been interested in placebo effects? What got you interested? Sort of what led you down this path?
Yeah, that's correct. I've been working on the placebo effect for more or less, yes, you're correct, about 15 years. We started in the 90s, more or less 94, 95. I am a doctor, I am a physician, so I was used to run different clinical trials. And we usually run clinical trials in the field of pain and analgesia, but also in the field of motor disorders like Parkinson's disease, like dystonia, like essential tremor. So I got interested in the placebo effect and placebo response in general, because when you run a clinical trial, actually you sometimes realize that patients who take a placebo actually get better than those patients who take the real treatment, the active treatment. So about 15 years ago, 15, 20 years ago, we decided to study what is going on. I mean, to understand why some people respond to placebos and why some other people do not. So I am both a clinical and a basic neurophysiologist, so I'm pretty much interested in understanding how our brain works. So right now, what I'm doing I'm using the placebo response and the placebo effect as a model to understand how our brain works. And it is quite interesting as a model because, there is usually people ask what is the mechanism of the placebo effect, but that's the wrong question. The correct question is what are the mechanisms, the plural. What are the mechanisms of the placebo effect? So when you study placebo effect, you can understand different brain functions like anxiety modulation, like reward mechanism, like learning, genetics, and so forth. So this is the reason why I'm working on the placebo effect.
Okay, I'm glad you stopped me from asking the wrong question there, because that's almost exactly what I had written down in my things to ask list. Let me ask you this. So when your average person is kind of, thinking about placebo, the first thing that comes to mind, they're thinking about, the mechanism behind it is essentially the power of hope or the power of expectation. Would you say that that's an accurate way of characterizing what's driving placebo?
Yes, of course, but we have to be very careful because expectation is only one of the mechanisms of the placebo response. As I said before, there is not a single mechanism, there is not a single placebo response. Actually, there are many. Just to give you a couple of examples. For example, we know today that there are both conscious and unconscious placebo responses. Well, just an example of conscious placebo response. Conscious placebo response is when we talk about expectation. Expectation effect, sometimes you can use the word expectation effect or placebo effect because expectation plays a very important role in conscious placebo responses. So what does it mean? It means that sometimes what you expect you get, actually, both with negative and with positive expectations. So in order to get a placebo response, you need to trust your doctor, you need to believe in the therapy, and when you expect something, actually, the link between what you expect and what you get, the link is twofold. The first mechanism is that when you expect a positive outcome, a positive therapeutic outcome, actually you can reduce anxiety. This is not surprising at all, of course. If I tell a patient, now your pain is going to decrease, actually there is a decrease in anxiety as well. The second mechanism is that you can activate the reward mechanism. What is a reward? A reward is a natural reward, usually is food. Chocolate, for example, for humans, chocolate is a very good, very nice reward, but food is a natural reward. Sex is a natural reward as well. There are some cultural rewards like money, for example. Money is a very powerful reward for humans. Well, a placebo is not different. A placebo is not different because a placebo can activate the very same mechanism, the very same reward mechanism as sex, as food, and money. In this case, the reward is not money, of course, is not sex, is not food. In the case of placebo administration, the reward is a therapeutic benefit, a clinical improvement. And can you imagine a better reward for a patient with suffering? The best reward for a patient, for a suffering patient, is a pain reduction. So this is the second link. The first link between what you expect and what you get is a modulation of anxiety. I tell you, the pain will decrease, your anxiety is going to decrease. The second link is that I tell you that there will be a reduction in pain. This is a powerful reward, so your reward mechanism in your brain are activated, like in sex, like in food, like for money. This is the first example of conscious placebo responses. But the second example is about unconscious placebo responses, because sometimes, you don't need to trust your doctor. You don't need to expect anything. You don't need to believe in the therapy you are receiving. Everything is unconscious. This is the example. Usually I use this kind of example because it is very straightforward. It's very clear. An example is an aspirin pill. An aspirin pill has a pharmacological agent inside. There is acetyl salicylic acid inside an aspirin pill. So acetyl salicylic acid is a powerful analgesic. But in the aspirin pill, there is not only acetyl salicylic acid, because a pill has a shape. For example, an aspirin pill is round. An aspirin pill has a color. It is white. So after repeated administration and after repeated association between the acetyl salicylic acid, which is inside the pill, and the shape and the color of aspirin, you can bet that every pill that is white and round will produce the same effect as acetyl salicylic acid, even if there is sugar inside and not the active pharmacological agent. This is a completely unconscious association between, the shape and color of. So these are the main mechanisms. I mean, today we know that there are at least these two mechanisms: expectation on the one hand and conditioning on the other hand. Expectation is a conscious mechanism, and conditioning is an unconscious mechanism.
But I mean, even conditioning, although conditioning is something that might express itself unconsciously, it's still, I mean, isn't it really the power of expectation? Because it's just unconscious expectation, maybe based on prior experience, rather than something that's actually making it to the light of our consciousness. Like, if you're Pavlov's dog, if you're conditioned to expecting food when you hear the bell and all that, and your mouth is watering, it's because of that expectation based on the food having been brought out to you in those conditions time and time and time again previously. So it's still expectation, even though it's not something you're consciously aware of. True?
This is quite a complex issue, actually. You are perfectly right. Actually, there is a lively discussion about this topic, whether or not conditioning is really unconscious. Because when you present, a conditioned stimulus, the conditioned stimulus in the case of an aspirin pill is its shape and color. So the question is there only an unconscious association between the pharmacological agent inside and the shape and the color of a pill, or you somehow expect something probably not at the conscious level, but at a subconscious level. So this is a big issue, not only for placebo researchers, but I would say for all neuroscientists, to answer the question whether or not conditioning is a really unconscious mechanism, or there is also a conscious component.
Okay, so one of the things that I found interesting when I was doing the pre-reading for this interview, and like borderline shocking, was just how powerful and prevalent placebo effects can be. One number that was bandied about as not being uncommon in clinical trials of new drugs was 30%, or sometimes even as high as 50% response rate to a totally inert placebo, which, that was higher than I would have guessed. I mean, to me, that seems really, really huge. If that's the kind of number that we're looking at, then what sort of the subjective effects, even from our active medications, can we really kind of attribute to that same placebo-based psychological underpinning?
Well, first of all, it's important to stress that there is a huge variability in placebo response. You mentioned 30%, the number of 30%, but I would say that it is not correct to talk about the 30% of responders. This is a common mistake, a common misconception. I would say that, unfortunately, there is a huge variability ranging from 0% to 100%. Very much depends. We are trying to understand why. And we have some indications that learning, for example, is very important. After all, a placebo response is a learning phenomenon, So if you, for example, we can take a as an example, we can take an analgesic drug, a painkiller. So if you give a painkiller like morphine, for example, you give morphine on Monday, you give morphine again on Tuesday, you give morphine on Wednesday, and again on Thursday, but on Friday you replace morphine with a placebo, you can bet that virtually all patients will respond. Virtually means more or less almost 100%, But if you give a placebo for the first time to naive subjects, to naive patients, actually the percentage is highly variable. I mean, it ranges from more or less 0% to probably sometimes 30%, some other times 40%. So we know today that learning is very important. So you can get placebo responders, very good placebo responders, and a very high percentage of placebo responders if you use a learning procedure. Morphine, then you replace the real morphine with a placebo, you can get more or less 100% of placebo responders. But if you give placebo for the first time, there is a huge variability. It's also important to stress that it very much depends on the medical condition. It very much depends on the disease. For example, depression. In depression and in general in neuropsychiatric disorders, like depression, like anxiety, general anxiety, obsessive compulsive disorders, but particularly in depression, there is a very high rate of placebo response, more or less. There are several studies showing that the percentage is more or less 75%, which means that only 25% of the response is a real pharmacodynamic effect. It's really due to the specific drugs. So 75 is really huge number. I mean, very huge. It means that in depression, probably it's more important psychotherapy than pharmacotherapy. And this is true for pain as well. Pain is very important in this sense. I would say that most of our knowledge about the mechanism of the placebo effect comes from the field of pain and analgesia. In pain, more or less, for example, in neuropathic pain, the percentage is more or less 50% or 60% of response. But if you switch to another medical condition like oncology, like cancer, for example, well, the placebo response is 0%. There is no real demonstration that if you give a placebo, be it a pharmacological conditioning or expectation or conscious, unconscious procedure or placebo response, in any case, in cancer, there is no evidence that there is an effect of placebo on cancer growth, for example. But if you give a placebo in a cancer patient to treat his pain, can get a very good placebo response. So it very much depends on the procedure you use, a learning procedure, or if you give a placebo for the first time, and it very much depends on the disease. In depression there is, and pain, there is a very high percentage of placebo response, but in cancer, for example, the percentage is, I would say, 0.
So I find myself wondering as I'm listening to you, do you find that there have been studies, have there been studies that looked at the variances in the type of people who are likely or not likely to show a strong response to placebos? Yeah, I find myself thinking about hypnosis and how there's some people that, really slip easily into hypnosis and other people that it's pretty much impossible to hypnotize. And it has to do with people's proclivity to being suggestible. Does that line up with the people that are or are not placebo responders, or have those studies not really been done?
Yes, there are. There are a couple of studies, probably more than a couple. There are 3-4 studies about hypnosis, and not only hypnosis, but also on personality traits, of patient. And there is a relationship between hypnotic suggestibility and a placebo response. The more you respond to hypnotic procedure, the more you will respond to a placebo. Yeah, there are a couple of studies. There are also some other studies, more or less, not only a few, not many studies about personality traits, but I would say 5 or 6 studies about optimistic personality, pessimistic personality. And in general, there is agreement that an optimistic tract, this is not surprising at all, is more responsive to a placebo treatment compared with a pessimistic trait.
Okay, so you just spoke there about positive people tending to be stronger responders to positive placebos. But, intuitively, I suspect that the opposite is probably also true, that it would be, even though it would be totally unethical or whatever to actually do this study, I'm assuming, if a doctor with a bunch of credentials and a stern, grave face came out and told you you've just ingested a poison and something nasty is going to happen to you, then you'd probably have sort of an inverted placebo, and that the people with the negative outlooks would probably be the ones that were sort of most primed for a strong response there. Is that also true?
Yeah, that's a very interesting question. The answer is yes, in general, because we we have the opposite phenomenon, which is the nocebo, what we call a nocebo effect. A placebo is due usually to positive verbal suggestions, which induce positive expectations. But if you tell a patient, and now, of course, this never happens in medical practice, of course, but if a doctor tells his patient, now your pain is going to increase because I'm going to give you a powerful hyperalgesic drug, so you have to expect an increase in your pain. Well, in this case, we use the word and the term nocebo response or nocebo effect. For example, paired with the placebo analgesia, we talk about nocebo hyperalgesia. Yes, that's very important. I mean, that's very important. You can respond in both directions, in the positive and the negative directions. And this is true for personality traits as well. If there is a relationship between personality trait and placebo response, there is a relationship with a nocebo response as well.
Okay, so I'm a Smart Drug Smarts listener. I'm hearing this, and I'm thinking about my medicine cabinet or my vitamin shelf or whatever. Yeah, and I'm hearing that based on what you're saying, placebo effects on these totally inert substances can be really, really high, and especially if it's like a learned response to a chemical that I've felt the effects of before. So if this is true, and this would be true even for an active compound, and this probably defies a general answer, but what % of the subjective response that somebody feels when they take, an over-the-counter drug or a supplement or even a prescription drug would you say is accounted for by placebo effects and not the active ingredients?
Yes, well, first of all, I would say that most of over-the-counter drugs are placebo, are nothing but a placebo. I would say that 90% of over-the-counter drugs are placebos for sure. Well, sometimes it is possible to recognize whether or not you are taking a placebo, depending on some side effects. That are very important. Sometimes the side effects are important to recognize if you are taking a real drug or not. This is important not so much in medical practice, in clinical practice, in routine clinical practice, but it is important in clinical trials. This is what we call active placebos. Active placebos are real medicine which are used for a different disease. For example, the typical example is an antibiotic. If you give an antibiotic for a viral infection, antibiotic is not useful at all. It is only a placebo. So in that case, if you give an antibiotic for a viral infection, an antibiotic does not kill viruses, of course. So if you give an antibiotics and there are some side effects of an antibiotic, you can have, sometimes a larger placebo response because you feel a strange sensation. You have a sensory feedback. For example, some antibiotics produce a metal taste, a metal flavor on your tongue, and that's a very important sensory feedback because the patient believes that that's a real powerful drug. So it very much depends on the patient's expectation. And sensory feedback, so side effects. Sensory feedback means side effects after all. And sensory feedback is very, very important to modulate the placebo response.
So we've been talking a lot about placebo effects with sort of the underlying assumption that there's a doctor in a lab coat in a medical environment and some of these, cultural triggers. But how much is this undercut or maybe the placebo effect reduced if someone is kind of just, buying a drug over the counter, or, and this is often the case with, nootropics buyers, that this stuff is just arriving via postal mail?
When you give a placebo, which means when you give an over-the-counter drug, you can observe a placebo response, but a placebo response could be a real psychobiological effect, a real psychological effect, but sometimes it's not It's not a psychological effect. I mean, it's not due to expectation. It's not due to conditioning. It's not due to anxiety reduction. It's not due to an activation of the reward mechanism. But it is, for example, that's very important. It's very important to emphasize this point. Can be due to spontaneous remission. And spontaneous remission is an important factor sometimes in recovery from a disease. In common cold, for example, over-the-counter drugs for common cold. There is no scientific study, actually, about common cold and the placebo response, but my guess is that in common cold, spontaneous remission is more important than the specific effect of the over-the-counter drugs and the psychological effect of a real placebo effect. In other words, when you get a common cold, the duration of a common cold is more or less 4 to 5, 6 days. You start taking an over-the-counter drug for your common cold after 3 or 4 days at the very beginning of the decrease of your symptoms. So you believe, mistakenly, that it is a sort of a wrong interpretation of the cause-effect relationship. This is true not only for common cold, but it is true for chronic pain. Chronic pain is quite interesting from this point of view, because just imagine a situation with a headache. Headache is a typical chronic pain situation in which there is a fluctuation in pain. Sometimes there is an increase in pain, sometimes there is a decrease. So if you take a placebo or if you take an ineffective drug at the beginning of the decrease, you believe that the placebo or the drug was really effective, but actually the pain would have decreased anyway.
So on this podcast, we're often talking about these cognitive drugs where there's not some physical somatic sensation that people are going to feel. It's not something distinct like pain stopping. Does this sort of the ephemeral nature of these cognition changing substances tend to make them more or less subject to placebo effects? I could kind of sort of see an argument either direction.
I mean, outside, not so much in a disease like pain or a symptom. But pain is not a disease, actually. A symptom like pain or a disease like Parkinson's disease, but in normal subjects. That's quite interesting, yes, because probably you are much more interested in smart drugs, to increase cognitive performance. And there is some preliminary evidence that a placebo response, there are some placebo responses both in cognitive performance, to improve cognitive performance and to improve physical performance. Well, of course, you can imagine that physical performance is important in sport. But, for example, we published a paper in 2007, more or less, 2007 or 2008, in which we used a placebo procedure to make the brain of an elite athlete to release endogenous opioids. When you give a placebo, you produce an increase in endogenous opioids. They are morphine-like substances in the brain, chemicals produced by our brain. And that's correct. And so by using a placebo procedure, we produce an increase in endogenous chemicals like morphine. And in that case, there was an increase in physical performance. So this is the first example of the effectiveness of a placebo in physical performance. But there is a very recent paper by a German group working at the University of Essen, and they showed that it is possible to increase, by using a placebo procedure, it is possible to increase short-term memory. And this increase in short-term memory is due to an activation of the endogenous opioids, because if you use the very same placebo procedure to increase short-term memory, but you block the endogenous opioids by using naloxone is a blocker of endogenous opioids, well, there is no longer, you can antagonize, you can block the placebo response completely. So there is some preliminary evidence, I would say, that it is possible to use a placebo procedure, and we are beginning to understand the mechanism as well, both in cognitive performance, for the improvement of cognitive performance and improvement of physical performance as well.
Okay, so I'm a listener, I'm listening to you now. On the one hand, maybe I'm a little discouraged to think that some of the benefits that I'm receiving from my medicine cabinet of nootropics is kind of either partially or fully placebo-based instead of the active chemicals. But on the other hand, I believe in what you're saying. I recognize that maybe placebo is a potential tool in my cognitive toolkit. Is there a way for me as a avowed brain hacker to use the placebo effect to my advantage? I guess what I'm thinking is if I can fool myself somehow into thinking that I'm smarter or feeling smarter, it seems to me that it's almost like a semantic difference between feeling smarter and actually being smarter. Can you riff on that?
This is important, particularly from, in cognitive performance. I mean, for intelligence, for memory, short-term memory and long-term memory. But it's important from an ethical and a legal point of view in sport, in physical performance. Because just imagine a situation in which you give, if you use a learning procedure, as I said before, if you give, for example, just imagine there is a competition on Sunday. And on Sunday, there is a competition. You can train a subject by using morphine. So during training, you give morphine on Monday, you give morphine on Tuesday, you give morphine during the week, and then on Sunday, during the competition, you replace morphine with a placebo. You can get the very same effect as the morphine of the previous days, but an anti-doping test would not detect any effect and any drug in the body. That's quite interesting. Yeah, because it's an ethical problem, it's a legal problem, and the question is an open question, actually. It is open for discussion. Is it ethical to perform a procedure like this? I mean, I train an athlete with morphine during the week, then on the competition day, I replace the ergogenic agent with a placebo. And is it ethical, a procedure like this? Well, that's an open question.
Okay, so thank you very, very much to Dr. Benedetti for sharing all those ideas with us. Really fruitful discussion, I think, kind of leaves me and hopefully you with a lot to think about. I think actually, now that we've talked about it, placebo effects are so relevant not just to medicine, not just to nootropics, but they're probably sort of all over our lives in ways we don't normally think about, or at least not under the name placebo, but sort of the power of both conscious and unconscious expectation in shaping our perceptual experience of the world is, wow, really, really very consequential. So yeah, lots to think about. You could probably get into a deep philosophical pinwheeling conversation about all those sorts of things and would be in pretty territory that would keep you going for a long time. So something to think about the next time you're kicking back with some friends and cracking open a bottle of wine or cracking open a jar of your favorite nootropic. Anyway, moving right along.
Smart Drug Smarts. Ruthless listener retention gimmick.
So, if you've ever thought about hopping up your surgeon on drugs before slipping onto the operating table, this article published in the Annals of Surgery from 2011, a couple years old but still relevant, would be worth taking note of. So, researchers at the Imperial College London and the University of Cambridge gave smart drugs to surgeons and then gave them some simulated tests that would be relevant to how they perform during surgery to see just how they did. You know, surgeons they work these famously long shifts and are called at weird hours and are sort of known to be sleep-deprived profession. They chose modafinil, the anti-narcolepsy drug, and also nootropic as their brain stimulant of choice. It's known to boost both memory and brain power, and then tested out how good these surgeons were at thinking clearly, solving problems, and carrying out simulated operations. Needless to say, for safety reasons, they didn't use real humans undergoing surgery in these tests. But they found the results to be very convincing, and Barbara Sahakian, who's a professor of psychiatry at Cambridge University, said, "We found that when the surgeons had taken modafinil, they saw sharp improvements in their ability to solve problems and think flexibly. In fact, their performance was very good." Sahakian suggested that modafinil could be a superior substitute for that long standby of the medical profession, caffeine, which, although it can keep people awake, can cause hand tremors, which is not what you want your surgeon to have. However, she pointed out that a key concern is that modafinil has not been subjected to long-term safety tests. Of course, modafinil has only been around for about 15 years, so the multi-decade test that one would really like will not be available for a couple more decades.
Smart Drug Smarts, the podcast so smart, we have smart in our title twice.
All right, so that is the episode. If you liked what you heard, and you can forgive me for having been so late with this episode, then please recommend this podcast to your friends and leave us a review on iTunes. The show notes for this show will be online at smartdrugsmarts.com, including the links to things that we mentioned here and some articles on placebo by Dr. Fabrizio Benedetti and others. I will be back with you very soon at the same time, same podcast, and the same unflagging commitment to helping you fine-tune the performance of your own brain. Have a great week and stay smart.
You've been listening to the Smart Drug Smarts podcast. Visit us online at www.smartdrugsmarts.com and subscribe to our mailing list to keep your neurons buzzing with the latest in brain optimization. Smart Drug Smart should be listened to for entertainment purposes only, although some guests on the show are medical doctors, most are not, and the host is just some random guy. Nothing you hear on this podcast or read at smartdrugsmarts.com should be considered medical advice. Consult your doctor and use some damn common sense before doing anything you think might have a lasting impact on your brain.